So I'm here to discuss about the role of this non-steroidal MRAs, particularly in the prevention of complications in diabetic nephropathy. This is, the leading cause of the renal disease is the diabetes, and at least 37% of our patients will have albuminuria, and we have a 10 times higher prevalence of renal failure in diabetic compared to non-diabetic. And of course, we all know this is a cardio-equivalent disease. So diabetics usually have 2 to 3 times more cardiovascular problem more so in female than in males, which leads to a recurrent hospitalization. And there is a common soil hypothesis in this as well. Most of the risk factors which are there will lead to not only cardiovascular disease, but also renal disease. And that includes, apart from diabetes, older age, male gender, smoking and hypertension. So how to identify renal disease in a diabetic patient? Usual trend has been to look at the creatinine level, and nowadays most of the lab gives you eGFR values. Because to you 1.3 creatinine may look like normal, but in a 75-year-old you have got a pretty low GFR. So you have to not only look at the creatinine level, you have to look at the eGFR, whatever formula you use, whether MDRD or CKD-PI, but the imperative is to look at the proteinuria level as well. Because someone who has got eGFR say 62, in this diagram you can see you may put him into the lower risk for cardiovascular disease. But the moment you add a proteinuria of more than 300 milligram, he goes into a high risk category. So it is the culmination of the both things which leads to early identification of the severity of the renal disease. So that is the important message. And most of the diabetologists do use USCR. It's like doing a fundoscopy in a hypertensive patient. So as a generalist also, you should be looking at proteinuria, which is a very cheap test to order and get a report almost on the same day. And here in this slide, you can see that not only the cardiovascular outcome as well as the renal outcome is worse once your USCR is more than 300 milligram per gram. But if you have a lower, the event rates are much, much lower. And most of the cardiovascular events will occur as early as 6 to 12 months. So just to give an example, if someone is proteinuric and a diabetic, I can assure you 90% of the time he will have a cardiovascular involvement, either in the form of subclinical LV dysfunction or he will have some form of atherosclerosis. So this is one of the simplest tests to find out whether my diabetic patient has got asymptomatic cardiovascular involvement, because identifying this thing will lead to a sea change in the management of diabetic medications. So it's important to pick up these cases, and as you know, the overactivation of MR receptor is most important, and most of these molecules which blocks, whether it is steroidal like spironolactone and eplerenone or non-steroidal, acts by preventing this mineralocorticoid receptor overactivation. And there are various mechanisms. It raises from reducing the fibrosis inflammation, leading to lower intraglomerular pressure, as well as various unknown features we are still evolving. It's not one mechanism by which preventing MR overactivation leads to a clinical outcome. This slide shows you the difference between steroidal and non-steroidal, just to highlight that it has got very little androgenic side effect like gynecomastia in comparison to a spironolactone. And of course, this is a very specific molecule and potency is almost similar to spironolactone. Whereas the downside is that the effect on blood pressure is very minimal, at least with Finerenone. There are certain other non-steroidal MRAs which is equally potent like spironolactone. So these are the few differences between the two. So we have to find out that in the previous trials in diabetic nephropathy where use of a RAS blockade, either ACE inhibitor or ARB is the rule, despite the use of RAS blockade, you have a lot of residual risk. Say in IDNT renal trial, you have a residual risk of even 50-60%. The later trials with the say canagliflozin, Credence trial, you have a residual risk still with 30%. With the use of SGLT2 inhibitors, still the residual risk remains at 24 to 28%. So whatever you do with the advent of SGLT2 and full usage of RAS blockade, there is a lot of residual risk, and that bring to the for the uses of MRAs. So whether it is steroidal, non-steroidal, so these residual risks will be taken care of. So if you use on top of say RAS blockade as well as SGLT2 inhibitor, nowadays there have been a study which was published few months back known as the confidence study. I'll come quickly to that. Before coming to the combination therapy, little bit about the evidence based on Finerenone. These are the two famous trials. We remember for a nephrologist it is Fidelio, for cardiologists it is Figaro. And if you combine these two data set, it becomes the fidelity group of data. So we've got very strong database on roughly more than 13,000 patients, which proves that it not only reduces the cardiovascular endpoints in the form of CV death and heart failure hospitalization, but also reduces the progression of deterioration of renal function, doubling of creatinine, or end-stage kidney disease. So this molecule has established its place in diabetic patients with nephropathy, whether this is only drop in eGFR or increase in proteinuria or a combination of the two. And this was the data that it will reduce around 22% reduction in heart failure hospitalization. Most of the data on SGLT2 is around 18 to 20% reduction in heart failure hospitalization. It is almost similar to the use of SGLT2 inhibitor, what I call is a credence-like population where you use SGLT2 inhibitor. If you use Finerenone, you will get almost the similar benefit. And similarly, the deterioration in renal function is 20 to 23%. Reduction in proteinuria is very potent. You use Finerenone, you'll be surprised that within a month, you'll get at least 30 to 32% reduction in proteinuria. And this benefit is maintained over long period of time, and in fact, it goes up to around 50%. And it does not come with a lot of side effects, unlike spironolactone. No androgenic side effect. Significant hyperkalemia is less than 2% in the data set I presented. By significant hyperkalemia, I mean more than 6. So we'll show you the algorithm how to manage a hyperkalemia if the time permits. So this is one molecule. Even if you analyze by intention to treat, on treatment, there will be a reduction in not only cardiovascular mortality, total mortality, heart failure hospitalization, and a worsening of renal parameters. So this is the confidence study which was published few months back. So those patients who are on RAS blockade, either ACE or ARB, they are on SGLT2 inhibitor, and they were combined with non-steroidal MRAs. Finerenone will show you the result. It's additive. So if you get a patient of proteinuria, just like in HEPREF nowadays, we have got 4 pillars. So RAS blockade, SGLT2 inhibitors, Finerenone, and GLP-1 receptor agonists. So this study confidence proved that there is a significant reduction in the primary endpoints. Secondary endpoints were also met in these patients where the inclusion criteria was UACR more than 100, and of course GFR has to be more than 25. So unlike the RAS blockade where cutoff is 30, for SGLT2 it is 20, for Finerenone it is almost 25. So even stage 4 patients of CKD can be included in these studies. So the confidence trial showed that if you use these two molecules on top of RAS blockade, it gives you an additional benefit. So it's important that you simultaneously initiate these patients with SGLT2, approved SGLT2 inhibitors, and non-steroidal MRAs like Finerenone, and you can have additive UACR reduction by 52%. So ADA recommends that at least 30% is the cutoff to get the benefit, and we achieve almost 52% if you combine these two medications on top of RAS blockade. It comes because of the reduction in blood pressure of around 4 millimeters systolic, 2 millimeter diastolic. And initially, just like SGLT2 inhibitor, you make a drop in eGFR, but this is inconsequential. You get initially eGFR drop of around 5 by SGLT2, almost to the same tune you get initial drop with Finerenone, but it doesn't come with extra cost. And of course, if you prime your patients with SGLT2 inhibitor, the chances that hyperkalemia will be less. So use MRA in that sequential fashion, RAS blockade, SGLT2 inhibitor, you take care of the potassium level, and of course begin non-steroidal only if your potassium level is less than 4.8. And if it is somewhere between 4.8 and 5.2, you have to be a bit cautious. Probably you monitor every 2 weeks rather than 4 weeks. And you always never stop unless it increases up to 5.5. So no knee-jerk practice that once it is 5.1 you start potassium bind therapy. That is a wrong practice to do. So we'll come to the protocol of how to manage potassium level. And yeah, this was the slide, I think. Yeah. So if you have got a potassium more than 6, of course you have to stop it. If it is somewhere between 5 and 5.5, do not increase the dose from 10 to 20. Stay at whatever the dose is. But if your eGFR is more than 60, potassium less than 4.8, you can always start with 20 milligram. So that's the usual practice pattern. And potassium or hyperkalemia avoidance strategy has to be there. So once you start these MRAs, always look whether the patient has uncontrolled diabetes, whether he already have uncontrolled heart failure, whether he's elderly, and depending on that you choose the doses. So these are the risk factors: elderly diabetes, heart failure, with increased concomitant use of other potassium increasing medications. You probably have to start at a lower dose, and increase should not be before 4 weeks. So usually first potassium check we do at 4 weeks unless you have started in a gray zone, and then keep on checking every 4 weeks. So what are the evidences in heart failure? So still there is no guideline from DCGI to use in heart failure, but we have got the data set like FineArts study which showed that up to the doses of 40 milligram there is a reduction in heart failure endpoints, particularly if your ejection fraction is more than 45. There is no role of non-steroidal MRAs so far in heart failure reduced EF. So less than 40% it is still no. Leave it to the specialist, particularly if someone is getting androgenic side effect even with eplerenone, then we have no choice than to use Finerenone. But barring that, there is no data set so far. But in heart failure preserved EF, we have got a published data that it causes benefits, and the FineArts is a proof of that. So I think I'll conclude here so that we can have some fruitful discussion on this topic. So just to conclude that if you get a diabetic patient with proteinuria, try to look it early on so that you get the best benefit. Even if it is advanced stage of proteinuria up to eGFR of 25, one should be using it. Just make sure your patient is on RAS blockade, good doses of RAS blockade. No point patient is not on ARB and ACE inhibitor. We started with MRAs. That's a wrong clinical practice. Make sure your patient is on SGLT2 inhibitor because combination will mitigate the side effects and it will give you better benefit. And of course, keep on monitoring the potassium levels and drop in eGFR so that you can temporarily withdraw. Once you withdraw, try to reinitiate the things. So I'll end it here. Thank you for the patience hearing.
Thank you, Dr. Pandey, for such a nice deliberation. After this FineArt trial, at what stage of heart failure with preserved ejection fraction do you start this combination of SGLT2 inhibitor and Finerenone? That is stage A and B. Of course, C and D are definite indication. But do you start at stage A or stage B, this combination, because it will prevent further progression of the heart failure in long run?
So the data is so far only with the RAS blockade, not with MRAs. Data is only with SGLT2 inhibitors. It will, so as a primary preventive therapy, so these two are the approved one. But once you have got a symptomatic heart failure, that is stage C, preserved heart failure, all three should be started simultaneously. That is RAS blockade, SGLT2 inhibitor and Finerenone, provided your EF is more than 40%.
Thank you, Pandey sir, for an excellent presentation on Finerenone. Basically, Finerenone has came into practice because of the understanding from the rat models that aldosterone is a part of inflammatory process, because in CKD, it's not just the glomerular disease, it's an interstitial and vascular disease as well. So aldosterone blockage gives the insight that what is the fourth pillar of managing kidney disease is probably the inflammatory process blockage, and that is where the Finerenone took its place. One practical point is, because most of these patients will already be on ACRB when you are starting Finerenone, it's always mandatory, possible mandatory, to check the potassium levels before you start Finerenone. And potassium levels can be given in your hospital between 2 to 3 hours itself. So if you can, patient can wait in your OPD and get your baseline potassium levels before you start this drug. So that may be a practical point. And the future is the FIND CKD trial. The FIND CKD trial will be a trial, it's in phase 3, will be evaluating Finerenone and SGLT2 inhibitor in a non-diabetic scenario. The one which was in confidence trial gave us the power to understand that there should not be inertia, that you, treatment inertia, start Finerenone, then wait, then start SGLT2 inhibitors. You leave the patient proteinuric for a long time. So you can start them together. So results are in front of you. And probably FIND CKD trial will give you the insight that whether we can use this in non-diabetic scenario. My question to you, sir, that when you have these patients in your emergencies, in your CCUs, getting admitted already on Finerenone, how do you titrate them when you have to use diuretics in addition to Finerenone?
So you mean to say with heart failure?
Yes.
Yeah. So the heart failure, the diuretics will be the mainstay. So it does not interfere with the uses or non-uses of MRAs. In fact, it will be a complementary. The only point is that one should not have a underuse or overuse of diuretics, because it cuts both way. In clinical practice, we see there is a little bit jump in creatinine. People stop diuretics and they'll end up in hospital within 2 to 3 days. So one should not be afraid of using diuretics. If permits, I'll monitor with the natriuresis, looking at the sodium level in the urine. So that's the best way to look, but it doesn't give you anything that we cannot use MRAs with diuretics. Regarding your non-diabetic, already there is a publication from China, at least 30 to 40% reduction of proteinuria in IgA nephropathy, around 70% reduction proteinuria in membranous nephropathy. So this is the data from Jiangmen in China. So already, although this is a single center experience, we have also got an experience it does work well in non-diabetic proteinuria.
It was an IgA nephropathy trial, and it was a short study for 6 months. In fact, there's a 2-month-old trial also using them together. Now my point is, would you stop Finerenone in a patient who is in an emergency, or will you continue it?
No, we will always continue.
Continue it.
Yeah.
Sir, can I have a question?
Yes, yeah. Yeah, you go ahead.
Sir, after starting Finerenone, it has been observed the creatinine level shoots up sometimes. What is your take on that? And another one issue, in non-diabetic kidney disease, does Finerenone acts how much?
Yeah, to the second question, I said there is a publication, single center experience. It does reduce by 40 to 70%, depending on the etiology. Mostly it works in membranous rather than IgA nephropathy, to little bit in Henoch-Schönlein purpura also. Coming to the rise in creatinine, most of the time where you are using Finerenone, they are either on very overzealous doses of diuretics, So probably you have to look at the volume status, try to reduce the dose of diuretics, usually it takes care of. And the rule is that if the jump in creatinine is more than 50%, probably you have to stop the RAS block at first, not the MRAs. MRAs we will stop only if the potassium increases, not the creatinine. So the step is optimize the doses of diuretics. If your jump is more than 50%, temporarily withhold either ARNI or ACE inhibitor or ARBs. If increase in up to 50%, do not hesitate. Try to maintain at the same doses and do not increase. If the jump is nearing 100%, you have to stop it and always look for the avenue when to restart in a smaller dose. So the trick is optimization of the diuretics and looking at the doses of RAS blockade which is on board.
Just to add to that question, sir, Finerenone works on the tubular glomerular feedback mechanism. So 8 to 10% of drop in GFR is expected for 2 months. If the GFR drop is more than 30%, it is said that look into other causes and reduce the dose, or if the GFR drop continues, then to stop that. I think if any more questions are there.
Thank you.
One last question.
Last one. Regarding creatinine, if weight is 50 kg, if a person age 65, creatinine 1.5, at same age, 80 kg weight, 1.5, there is some difference or not?
Yeah, you just open your mobile, look at the app, CKD API, there will be some difference. Age, body weight, creatinine level. There will be a change. Yeah.
In diabetic with hypertension, we usually start with the ACE inhibitor or ARB. That will reduce proteinuria. So now we are getting more and more diabetic kidney disease patients with normoalbuminuria. In such cases, is Finerenone indicated who are having normoalbuminuria along with reduced eGFR?
No. So answer is at this point no. In China and Japan, use of MRA is approved only for hypertension, but not the Finerenone. It is Esaxerenone in Japan. So as a case of resistant hypertension, you can use MR inhibitors, particularly steroidal. Non-steroidal only approved in Japan, not in any other parts of the world.
Thank you.
Thank you.
At present, difficult to answer because in that there was a sub-analysis that they prevent microproteinuria, but if it's an add-on drug on ACE-ARB, so if your proteinuria is controlled on ACE-ARB, you can very well, jolly well wait. So we'll say close the session today. Thank you very much, sir, for the excellent presentation.
Speaker, sir, please be there. I would like to request Dr. G.P. Bhattacharya on behalf of Howrah Diabetic Society. Please felicitate our speaker and chairperson. Thank you, Speaker. Thank you, Chairperson. Thank you, GP sir.